Yes, thank you, Professor Khanna. I hope that you can see my screen and you can hear me well.
Absolutely.
Thank you. It's a pleasure for me to be here, and sorry if I had to anticipate this because I have a TAVI patient who's waiting for me. But I'm really happy to be here again, and hopefully next year I will be able to join you directly like 2 years ago. Yeah, I'm going to present you a case of TAVI zero contrast, but also will share with you for the first time our experience with a few case series with patients treated with zero contrast in TAVR. So this is a case of an 83-year-old woman which had the history of coronary artery disease with several revascularization, and she had several several hospitalizations also for heart failure and acute pulmonary edema. So this is the reason why she came at our hospital a few months ago for a worsening heart failure symptoms. So she had, for the first time, we discovered a chronic renal insufficiency with a glomerular filtration rate of 15, serum creatinine was 2.7, and the echocardiography showed a severe ventricular hypertrophy with severe aortic stenosis and the depression in the left ventricular ejection fraction at 37%. So diagnosis was there with severe aortic stenosis, and this was the angiogram, which showed a pretty good result of previous revascularization with stents and drug-coated balloons for coronary arteries. So nothing new. So we discussed about this case of an 84-year-old lady with severe stenosis of the aortic valve. And so obviously, like we do in almost 100% of the cases like these, the decision was made for doing a TAVR in this patient. But the problem was the CKD. So what is the literature telling us about this? The first point is that many of our patients undergoing TAVR are elderly and have severe other comorbidities. And many of them have documented chronic kidney disease, and another good portion of them is at high risk of renal insufficiencies after the TAVR. So this is one of the most important points regarding these patients to date. There is also a good number of patients which after TAVR is showing an improvement in the renal function after this intervention. So this is another indication, another strong indication for doing TAVR in these patients. From the literature, about 1/3 of the patients undergoing TAVR in Europe and in the US is showing a chronic renal disease. And as I said before, another 20% is at high risk of developing AKI after TAVR. And what about the outcome after TAVR? In 60% of the cases, there is an improvement in the renal function, but still we have a decrease in the renal function in 40% of the cases, with 12% of the patients which experience a fully recognizable AKI after TAVR. What about the outcome? What we have seen at short follow-up after 1 year is that patients which develop AKI after TAVR is going to have a higher morbidity and mortality. Mortality is increased up to 40% from this study from Spanish centers, whereas patients without AKI have a mortality of 12%. So mortality is 3 times higher and more if they experience AKI after TAVR. What about 4-year follow-up with patients which develop dialysis or high-risk TAVR, high-risk AKI after TAVR have a mortality of 91% after 4 years, whereas patients who do not develop AKI have a 39% of risk of mortality after 4 years. We all know that before TAVR, all of the patients should go coronary angiography either or CT coronary scan, which means to bring them a minimum of 25 millimeters of contrast dye, which may become even more, up to 100 in case they undergo PCI. And then many patients need also to have a CT scan for the procedure and also for the accesses. And so here, the total amount of contrast is getting lower than previously, but still at the minimum of 80 millimeters up to 120, 140 millimeters before. And then there is the intervention of TAVR, which is related to pretty high amount of contrast. So the total amount of contrast given 3 different times is very high in these patients. So this is why we wanted to have to see with our foundation, which is our experience with this, with a new TAVR, a new device, which is the Accurate Neo 2 valve, which is a valve which has a low size of the introducer, and has a very high deliverability. So we got experience with 6 patients which had an average age of 84-year-old. All of them were female, so this is quite strange if compared to the literature, and were, I would say, very complex milieu from the clinical point of view. NYHA mean was more than 3.5, so patients were really symptomatic for heart failure. Creatinine mean was 2.3 milligrams per liter, and the hemoglobin was good. So left ventricular ejection fraction was pretty good on average, 51%. And what about the intervention? We did local anesthesia in all of these patients, so no general anesthesia in these patients, 0 contrast. And what is important is that we didn't give any contrast either for the CT scan before the intervention and also for the intervention. Prosthesis size in 3 cases was medium and in 3 cases was large. We did predilatation in 66% of the cases and spondylitation only in 1 case. And what about the acute outcome? We had 0 complications, 0 moderate or severe paravalvular leak, and a final gradient of 6.6 millimeters. This is the size of the Accurate valve Neo 2 that are available in Europe. We have the small, the medium, and the large, which is able to accommodate a perimeter of the aortic annulus between 79 up to a maximum of 85 millimeters. We have a short follow-up for this patient population. At 4 months, we had 0 MACE, and NIA was 2.3. I reckon you that it was 3.6 at the beginning. Creatinine was still there from 2.5 to 2.1. Hemoglobin was still there. Left ventricular ejection fraction had a slight improvement, and the gradient was still there. But importantly, we had no paravalvular leak, either moderate or severe extension, and no permanent pacemaker in this small population. So coming back to our case, we decided to do TAVI, and we opted for 0 contrast TAVI given the high risk of ACI in this patient with still an initial renal insufficiency. With the CT scan, we are able to have a good analysis and evaluation of the valve, mostly if we have some calcifications. Otherwise, it will be a little bit difficult. But in this case, we were able to go for correct diameter analysis, and also the height of the coronary arteries was pretty good. Regarding the access, was performed with a Doppler ultrasound, so we were able to check for the correct dimensions of the vessels, the tortuosity, and the calcifications up to the iliac arteries. This is the report, which was quite normal as other reports done with the CT scan done with contrast. So we're able to do all of the normal items that we do usually for our patients. So patient underwent mild sedation with local anesthesia. We put a temporary pacemaker, and we had 2 ancillary arterial secondary accesses, one by the left radial artery and the other one from the left femoral artery, putting 2 pigtails. And then we had the major access site from the right femoral artery. Then we pre-closed the first one with 1 proglide, and in the end we had to put 1 angioceal. Sometimes we have to use 2 proglides and 1 angioceal for the main access. Then we decided which was the best implantation projection according to the 2 pigtails in the non-coronary cusp and in the right coronary cusp. Then we cross the aortic valve. This is the shot where we can see the correct positioning of the two pigtails. And this is a valve which has been deployed a little bit lower, and then this was a large one, a little bit lower than the actual positioning of the aortic annulus. And this is the valve deployment. So you can see no contrast here from the pigtail, and this is the final deployment. So the valve was implanted with no complications, no significant transvalvular gradients, and no paravalvular leak. We did also an echo scan, since we didn't want to do any contrast also after the interventions, and there was no significant regurgitation. The patient was discharged after 3 days without complications, but with a significant improvement in her condition of clinical symptoms. We have a follow-up of 3 months in this patient, so no regurgitation from the echo. And also here we had an improvement in a mitral valve regurgitation, which was present previously. And this is the valve with a good expansion of the prosthesis without paravalvular leaks. So my conclusion is that post-TAVI acute kidney injury is a frequent procedural complication associated with poor prognosis and increased mortality. In patients with CKD or at high risk of a zero contrast technique should be considered, at least with this new type of valves like the Accurate Neo2, which is particularly fitable for this type of procedure. And I thank you for your attention.
That was wonderful. Can you hear me? There was some problem with the audio.
Yes.
Okay, so that was a wonderful way to go out, and I think in future we'll have many more indications and many more patients who would be benefited by a zero contrast TAVI. And I think what's really going to help also, or may help, is image fusion. If you can do an MR or a T image fusion with your in the cath lab, it may probably guide you much better, and you have additional sort of assistance in terms of doing the, putting in the valves accurately and having a zero contrast TAVI. So thank you very much. That was really unique and quite wonderful talk.